Yeah, we kind of
in the literature.
we read about
And
we read about you
and
and
books, and then we
right.
actually get to talk to these. It's a joy for us too. Yeah, it's very fun.
We have a lot of fun doing it. So in 3 seconds, we'll start as soon as you're ready.
Go right ahead. You want me to roll in on this too?
Yeah, it's fine.
Okay.
Go right ahead. Ready?
We're good?
And 3, 2, 1.
Well, welcome back to the Dental Guys podcast. I'm John, the Dental Guy.
And I'm Wes, the Dental Guy.
And we are here with Dr. Nadim Baba. And the topic that you're going to be speaking on later today really is interesting because it is a topic that we've talked a little bit about on the show before, which is CAD/CAM fabricated dentures. And the title is A New Paradigm in Removable Prosthodontics. And I think we have kind of been wondering when that new paradigm is going to be at the point where we can say, this is it. This is the time when it is there. So first of all, thank you for being with us today.
Thank you for having me.
Yeah, we're excited to talk about it. So let's dive right in. Let's talk about
let's talk about why we love dentures.
Yeah,
right?
yeah, dentures.
Because we have said that setting 8 and 9 is like the beginning of understanding aesthetics, right?
Right.
And
everything.
a wax rim and just love. I mean, like we love that
right,
stuff.
but
right?
this is all the conventional process.
Right.
So what I wanted to understand is what can we do now in the CAD/CAM world? Because I think the things that come up are we talk about accuracy and fit.
Yes.
We talk about impressioning and can we capture movable tissues with a scanner versus taking a conventional impression and then scanning that. And then we also talk about time. And are we going to add time to our appointments in the end, or are we taking away? So let's maybe get into just from the beginning, let's talk about accuracy first maybe. How good are CAD/CAM denture bases?
Well, first of all, thank you for having me. It's a great pleasure to be here. And to answer the first question you ask, when is the time to go into CAD/CAM?
Yeah.
The time is now.
Yeah.
Let's see. We have been using CAD/CAM in fixed. We've been using maxillofacial, been using an implant. And complete denture is the last to get into that. But the problem is we have a shortage of qualified dental technicians. And then it's been shown through the statistics that the number of dental technology schools is dropping down. The number of technicians going into the business is stable, but it's not that high. So all of this has pushed us to go into the CAD/CAM world. And we all know that complete dentures are not going to disappear. So if you look at the statistics, there's approximately 27% of the population in the United States is edentulous. That means we have a lot of teeth to replace. So that wouldn't be a problem. Now, the difficulty for people is that any time you go into something new, it's scary. See, we've been doing dentures for so long, the same way, grabbing an impression, putting the cast, making a base plate wax trim, setting teeth, festooning, whatever, until the dentures are fabricated. But suddenly, you're taking that and you're telling somebody, hey, what you're going to do is just do the minimum steps, and then the computer is going to take the remaining and digitize the dentures for you. So now here, it becomes also actually more difficult because you need to understand you're talking about 8 and 9. And again, we learned that from fixed. That the aesthetics we learned from fixed, the midline, the smile line, the curvature, all of these things we learned from fixed, and then we're applying them into complete denture. But here with CAD/CAM, that you got a computer doing that for you, setting the teeth on the ridge, not higher than 2/3 of the retromolar pads, getting the exact overjet and overbite. There's computers doing that, so you don't really have to sit down and physically do it, but you need to understand it. So they're becoming a little bit more difficult because you have to understand the principles of removable in order to go into CAD/CAM. Because as you mentioned earlier, you can get an analog impression like you've always done, and the lab technician can either scan it and digitize your case, take it from there, or you can scan intraorally. The problem with removable is you have no teeth. So if you scan the maxilla, you scan the mandible, you can have a way to put them together. You still need kind of a wax rim. You still need probably a duplicate of the existing dentures that patient has been wearing for a while. You duplicate them and you go from there. So the if you don't want to go analog, you say, okay, I'm going to go completely digital. The difficulty is here when you have natural teeth and you take in different images. The software has the possibility to stitch the images together to build up the whole arch. Now here you only have soft tissue. So it takes a certain level of understanding of how to do it and where to start, and it has to be continuous when you do it. So we've published an article a couple of years ago just to kind of give a guideline of what to do when you scan an arch. Now, you can imagine now, if you scan in an arch, you need 4 hands. You need 2 hands to retract and your hands to scan. So, and we learned that maxilla is easier than the mandible. The mandible, you have the tongue, the saliva, the undercuts, and the retromalahyoid fossa. Could be an issue, specifically if the head of the wand is big, you can't go into that space, or the patient has a huge tongue. So these are issues that you're going to have to deal with. So again, there's a learning curve. So when you start, you're going to have difficulties that you're going to have to adapt both to your scanner and to a new procedure. So it's not easy, but with time, so the more you do it, the better it becomes, and the more comfortable you become.
Do you feel comfortable saying that there's a workflow now for scanning the arches versus taking an analog impression?
Yeah, there is. Of course there is. But you can still do both.
Yeah.
So if
You don't have to choose one.
No. So
Right.
it depends on your comfort zone.
Right.
If you're comfortable doing an analog impression and send it to the lab so they can scan it, why not?
Right.
And if you're comfortable, you don't want to do an impression, you just want to scan the arch, you can do that.
So we can live in this digital realm of having some abilities software-wise to do some pretty amazing things, set 8 and 9, before we even put it in the patient, and really hit on all marks before the first wax rim goes in, whether you scan it or take an impression. The lab moving from that analog model to the digital realm. Tell us what's going on right now with, like, I get excited about tooth molds, but it used to be that we just pull out a book and you had a list of things to choose from, but now
you still have to do the same.
Right. Okay.
But instead of, so what you want to do is once you've digitized everything. So let's say you start with an analog impression, you send it to the lab pulls your cast and gives you the wax rims. You try them in, just the lip support for that, you use the vertical dimension and everything you traditionally do, and grab a centric relation record. Then you have to take that mold and pick up the teeth. Of course, then once you do that, then the lab in his software, depending on what type of system he's using. Like, for example, if he's using the Ivoclar system. Now, in the Ivoclar system, there's the Ivoclar library. So what you can do is you look at the mold and you say, okay, I want this mold for my patient, and you choose it. And that mold is exactly the same what you've picked in the catalog. Now, some companies don't have that luxury because they have the system of fabricating a complete denture, but they don't own the library.
Right.
The beauty of Ivoclar is that they have a digital workflow for complete dentures. They own the library, and that's why it makes it a complete system.
Right.
It makes it
Good.
easier.
So let's talk about jaw relation records, because I think that is the area that, at least from what I see from the outside, because this isn't an area that I've not dived into this at this point. What does that appointment look like if we're in the CAD/CAM world, the digital world for dentures? Because I've seen some pretty sophisticated looking apparatus that's going into the mouth. And where are we with that now, and what's the learning curve like for that?
For complete dentures, it's practically different steps. So again, if you start analog and you get to the wax rims, you just have to take your centric relation record, and the lab will digitize it from there and fabricate your dentures.
Okay.
The other approach, if you start with a scan, an intraoral scan, now you're going to need something to put these jaws together. Then what the lab will do is virtually fabricate the wax rims, print them for you and sends them to you. You adjust them, get that vertical, and he'll take it from there. The easiest way is if the patient is wearing an existing denture. Now, of course, the vertical might not be correct, might be a little bit less or a little bit more, but what you do is you duplicate these dentures, use them, at least you have a starting point.
Yes.
You open the vertical, let's say, you grab your centric relation record, and you take it from there. So it's very flexible. People are scared because it's new.
Right.
People are scared because of the unknown.
Yeah.
But if you look at it, really, I mean, it's a very straightforward procedure.
Now, there are different approaches once you get to the actual manufacturing of the dentures, as far as, are we milling a base? Are we printing? Are we using prefabricated teeth that are being set into that and cemented in or bonded in, or are we making this a monolithic restoration? You know, talk a little bit about those different options.
Of course. Now, people are going crazy about printing. And I know that, you know, everybody wants to buy a printer and print their own dentures. The reality is, it's a technology that is here to stay. Is it prime time? No, it's not prime time. If you look at the studies, and we conducted a study at school also, to look at the physical properties of printed material, there is a lot of unknowns that we don't know. Biocompatibility, adherence of bacteria to the base, stain, fracture strength, wear resistance. There's a lot of things we don't know. Of course, now, again, it's something that will stay, but it will need a lot of improvement before we're comfortable with it. Now, as a clinician, does it really make a difference for me? It doesn't. I get them in a Ziploc bag anyway, either where they're printed, mailed, or conventionally processed. I get them in a Ziploc bag to deliver to the patient.
Right.
So for us, it doesn't really make a difference. It does make a difference for the lab technician.
Okay.
That's where they save some of the money. Now, you ask me about the teeth. Well, some systems print the base and they bond the teeth on them.
Yes.
So now, I have an issue with that, because if you design my denture on a software, you print the base and then you're bonding the teeth manually, which means that you're not following whatever you designed. So, which means that 100% you're going to have to do a clinical remount to adjust the occlusion. Now, it is much better if you have the teeth milled. Now, the Ivoclar system, for example, gets you the teeth and the base milled, and then the occlusion is adjusted on the computer.
Really?
So what we call adaptive occlusion. So you get a balanced occlusion on the computer, and when the teeth are milled, they milled balanced. So now there is something that was just launched here in Chicago. It's called the iVotion. It is a block of a PMMA that has the base and the teeth material in one block. So when you mill in a monolithic complete denture.
See, now that's starting to make more sense to me.
Yes.
Yeah.
Yes.
So
Now
the teeth are not bonded. It's
One piece.
Yes.
And
Okay.
so that's
Okay.
interesting, because like when I first saw these years ago, I thought, man, it's like, that's cool, but they don't look aesthetic.
Right.
And how aesthetic is this getting?
You will be surprised about the quality. First of all, the milling machines are getting better. It's a 5-axis milling machine, and they're getting even more refined than they used to be 5 years ago. The engineering is much, much better. People are understanding much better what to do. So the results are really phenomenal. I mean, you look at these, the papilla. This is where most of the issues are, is to be able to mill the papilla area.
Yes.
Right.
And because milling the teeth and the occlusion, that's easy.
And that interface there with a bonded tooth, I always worry about that fine line right there of what's going to stain.
Right.
And patients coming back and saying, I can't get this off, and it is that interface where maybe bond broke down or whatever happened.
Yeah.
So having a monolithic thing, I can see how that's going to be more aesthetic. It's going to
Yes.
hold up better long term.
And stronger.
And probably, well, for sure, stronger.
And it looks like this from the studies, going back to the other concern that sometimes people have is about fit. From the studies I've seen, these bases are fitting amazingly well.
CAD-CAM, if you look at all the studies, CAD-CAM milled PMMA has much better fit than printed bases. It's
Really?
a reality. Well, printed bases are made of resin. They do shrink. So when after you print them, you have to remove them from the plate, put them in a curing device. So there's a risk of distorting them.
Yeah.
The study that we did, we found that there's 100 to 300 micrometer difference in adaptation. Now, is that really significant? Maybe not, because you're doing PIP anyway to adjust it. But studies have shown that the printed bases do shrink on the buccal shelf area, do shrink on the retromolar pad area, and do shrink on the posterior palatal seal area. They do shrink. So now, if you look at the milled, it's a pre-polymerized puck.
Yes.
It's already shrunk. It's so stable. You mill it, it's not going to change. And again, so this is the beauty of the milling versus the printing.
And then coming back to that appointment where we're trying this in, and, I'm going to go old school here. I'm a hydrocast guy. So, I mean, I love functional impressions. I love walking impression technique and branching technique. If you wanted to come in and do something like that where you had your palate as a hard stop or you had a jig and you were going to insert that and add hydrocast to border mold.
You can.
And you can, and then reline this material?
You can. Now, if it's milled, well, it's PMMA.
Right.
So, for example, Ivoclar uses Ivobase. If it's milled and you want to do your technique, of course, you just give the patient the dentures. He comes back, then all what you have to do is use the Ivobase to reline your
really?
Yeah, you can do it. I mean, it's easy. Now, if you're doing printing, that's pretty much difficult.
Yeah.
There's nothing bonds to the printed material.
That's interesting.
Now, we've tried in the study that we've done at school, we looked at different reline material to figure out if there's any reline material like Viscogel, CoSoft, you name it. We tried many of them. And then none of them could bond to the intaglio surface of the printed resin.
Now, I didn't know that.
So that's the difficulty. I mean, and I hear people saying, oh, it's not a big deal, I'll print another one. I mean, do you think is it cost effective for you to print a denture every 90 days for your patient?
Right.
I honestly, I don't think that there's
Well, you have some patients that are debilitated and, they require some I mean, these are one-offs, right? But
Yes.
there's still the ability to be able to do some chair-side reline procedures.
Yeah.
Things like that.
You have to be able to do that, or repairs even, things
Yes.
like that, simple procedures. What about for immediate dentures? Where are we in that
I was
world?
going to get into
Yeah.
that faster than me. So I've done many immediate dentures following the digital workflow. Again, the beauty, because they melt, it's a PMMA. So after 6 months of healing, so what you have to do, traditional border molding, and then reline your dentures. Now, the problem is if it's printed, unfortunately, you're going to have to make an impression and print another base.
Yes.
So
that's where, again, you really see the limitation of not being able to reline.
the other thing is repairs. Look at now, patient drops the denture, okay, breaks a tooth, or breaks it. You can repair it. It's PMMA. When it's printed, you can't repair it. You have to make another one.
Well, one of the most recent advertisements I saw for a particular, I won't mention the product name, but the printed, they were running a truck over the printed.
So how scientific is that?
Right.
Exactly.
It's
It's
ridiculous.
marketing, but what they're showing is they showed another competitor's product there, and if you don't really understand the limitations of the printed, yes, it might be stronger per se, but the repairability here. Right, to me is so important.
Yeah, that's a problem, and the wear, and like you say, all the other unknowns, the staining, the wear.
Aesthetically also, if you look at the printed material, they're all
monochromatic.
Monochromatic.
Yes.
There's, and it doesn't really reflect in A2. For example, if you pick an A2, you print the teeth A2 and you mill the teeth A2.
Totally different.
What about the pink? I mean, is there fibers built into this milled pink resin that you're talking about?
Yes.
So you do have some of that, because I love the way that looks whenever light hits that. It shines and reflects naturally.
The printing is, that's another place where we've seen issues. I mean, the pink is not, it's often not pretty.
No.
It looks like a pink lipstick. I mean, it kind of sticks out. And
somebody has a gummy smile.
Right.
It shows
It
a
can be
lot
a
of
problem.
It's a big problem.
Yeah, it's an issue.
I think that's where, and we're talking a lot about printing these days, and everybody wants, well, not everybody, but a lot of people, they want this printer. It's just cool. It's cool. It's sexy. But I feel like it's we're still searching for maybe the right application for that in this. What do you think that's true? I know we have applications in the fixed world, but
that's true. I mean, it's beautiful to have a printer if you want to place your implants.
Yes.
Patient has a complete denture. You scan it, get a surgical guide, print it out on the spot, get it done. That's an application.
And rapid prototyping for hybrids, things like that.
That I agree with. But the issue is, okay, you're saying it's sexy, it's nice to have a printer. It's cheap because you can buy a cheap one for what, $3,500, but you can't buy a mill for $3,500.
No. Yes.
Yeah, but the reality is, for us as a clinician, what difference does it make if it's conventionally processed, milled or printed? I get it in a Ziploc bag and I'm going to have to deliver it.
Right.
So the only difference it does make, and then we looked at timing between printing and milling, and we found that honestly there's not a lot of difference, because in printing, that you have to, after you print, which takes a long period of time, depending on your printer, of course. So if you buy the low end, I'm not putting down any company, but if you buy, let's say, the $3,000 printer, it's not going to print as fast as the $50,000 printer.
Right.
So if you buy the low-end printer, okay, it's going to take you a long time to print. Then you're going to have to cure it, clean it and cure it, then bond the teeth, and then after that, you're going to have to polish it. Now, in the milling, that you just design, that's what takes most of your time, and the machine does the remaining, and you just barely have to polish at the end. So we compared this printing to milling, and honestly, it wasn't a lot of difference in time. It was like people are claiming. I personally did put some numbers together to figure out, is it more comfortable for me, I should say, more cost-effective for me to do a conventional denture or mill? Or like get my dentures milled.
Yes.
So I looked at the money. I looked at the clinical material. How much does it cost me plus my chair time? And I looked at the lab. So then I look at how much would it cost me as a prosthodontist in my own lab to make a conventionally processed denture, and how much does it cost material-wise to get a milled one? Funny enough, it was only $35 to $40 difference.
Really?
Wow.
Now, chair side, and to answer your question that you asked me at the beginning, it does make a big difference because you're spending less time chair side.
And that's where the money savings is.
That's exactly right.
Yes.
So it doesn't make a difference for you in the lab, but in chair side, what makes a difference is you are spending less time chair side with the patient, and that's what kills our office, is that chair time, that overhead.
Yes.
So instead of a 5-appointment denture, if I can make it 2 or 3, wow, I'm saving money.
Significant.
Now, I'm sorry to interrupt you, but at the delivery time is also your time is shrank because the dentures are so comfortable, they fit so nicely, and the post-operative visits have also been reduced.
And has that been researched? I mean, are you all doing
post-op visits,
post-op visits stuff on that, like sore spots?
There's no published research, but what we do is we
survey
among us. We
and you're seeing that in your practice,
in my own practice.
Well, I mean, flasking is gone.
Is it a thing?
And digital dentures are here to stay.
Now, but you have also to look at it. Now we are in a country where we're lucky that we are state of the art.
Right.
In some countries, they are still going to flask.
Of course.
And still going to do the conventional work. So, but I agree with you. In North America, I think CAD/CAM dentures are here to stay, and the time is now. So those who are still reluctant or scared or worried, I think they shouldn't. They should start getting into it.
We should jump in then.
And it sounds like really the lab is where a lot of this begins. If you are, the labs have to be the ones that truly get on board with this, right?
And if your lab doesn't have the mill, if your lab doesn't have the software,
then they can't
even
do
if you want to do CAD/CAM,
it doesn't matter how much you want to do it.
Doesn't matter. Now, if you talk about cost-wise, between conventionally processed denture versus milled, I'm talking, let's say, maxilla and mandibular, CD over CD. Again, it's practically the same price. You're paying for the lab the same amount of money. But what makes a difference for the lab is to fabricate a conventionally processed denture. Takes him 9 hours of just putting that in the water bath is 9 hours, plus all the other thing, versus 2 hours or 2 hours and a half to give you the
Right.
same dentures.
As long as they can make the capital investment
Yes.
in the mill. And I mean, are these mills expensive, say, compared to Crown and Bridge mills? Is
They're
it
practically the same
practically
cost.
the same? Okay.
And is it something that's dual purpose too? If you had a lab that say was already doing
Yes.
some milling, is there dual
Like,
purpose?
can they mill surgical guides on the
Yeah,
same?
some of the mills could do both fixed and removable at the
Okay.
same
Right.
time.
Right.
Well,
Wow.
I think I've been challenged, you
I think
know,
we both
and
have.
and this is something that, I mean, again, we've seen it. I've been to some lunch and learns and some like these small courses, but this is the first time I feel like I'm hearing
John,
from
I'm gonna
somebody
call
who's
you.
doing it.
I mean, you're the old man.
I am.
Right, and I think
it's
I'm
true.
going to dive in because Bob and I were just looking at a case the other day, and I'm like, he was like, Wes, we need to be milling this base plate.
Yeah.
Definitely,
He said, I think we're ready.
Yeah, I'm going to
so
try it.
I think it's time
time.
to try. And
It is.
you've really helped us
Yeah.
today.
I'm
And
glad I did.
tell us a little bit about where people can find you. I know you're a teacher and you're heading up some pretty awesome stuff there in Southern California.
Yeah, thank you. I have my own practice in Glendale, California, and I teach part time at Loma Linda University in the implant department. I'm available on my email. It's nbaba@llu.edu, and I'm more than happy to answer any
Wow.
question anybody has.
That's awesome.
Awesome. So if you're a lab technician, if you're a clinician, if you're a student, and you're wanting to get involved with this, I mean, obviously the question is, where do we start? And this is a great resource who's, you know, obviously been heavily involved, not only the research side, but the clinical side. And I'm certainly going to get involved. I think it's time. So,
well, I think it's time, and I think of how are you involved with Quintessence? Because we didn't really talk a little bit about that.
Well,
but
I did publish a book for Quintessence in 2012.
okay.
It's on the restoration of endodontically treated teeth.
Okay.
And now I'm writing a second one. I took over Schillenberg's book.
yeah. Oh,
So
man.
Oh,
I'm
wow.
revamping the whole thing. So
Wow.
Love it.
Big
Love
shoes
it.
to fill,
yeah,
but
I don't only do dentures. So
Right. we like to save
That's
teeth, right?
great.
Yeah,
Right,
of
we
course.
like
That's
to
great.
save teeth.
Well, if you've enjoyed this podcast, this show today, give us some feedback. Follow us on our social media outlets, Instagram, Facebook, YouTube. And check out what Dr. Bob is doing, you know, and get involved with what he's doing. And if you see that name come up, it might be somebody you want to check out as he's getting involved in more writing and more teaching. And once again, it's been a great meeting. Thanks again to Quintessence for helping to get us here to the American Academy of Fixed Prosthodontics meeting. We look forward to talking more with you over the next couple of days. So for Wes and John and Dr. Baba, we are the Dental Guys.
thank you, guys.
Thank you. All right.
But, before you take your mask, I want to take a photo with you.
Oh yeah,
No,
that's
no,
awesome.
There you go.
Yeah.
Thank you so much.
That was great.
This was so fun.
Great. It was
Yes.
fun. It was also, I mean, it really.
I'm usually not comfortable with this kind of stuff, but because my relationship with Quintessence, some people, you know, they
Right, we understand. Right.
issue here and there. They
And
want
it
you to
really
say
helps.
things, but I love it. I'm thankful very much.
Well,
It's
good.
really interesting.
Thank you for that feedback, because we really, that's the reputation we're trying to build, is we want to let people be themselves, talk about what they're interested in, and we're learning right along with our audience.
So how does it work? So there's people listening to you live?
Yes.
Yeah, so the main show, though, is a podcast. So
Right.
it's audio only. So you can subscribe on Apple
Yeah.
Podcasts.
So every 2 weeks we release a show, and we'll have, you know, a bunch of people download it and listen to it. We are on YouTube, so we do have a video as well, but it's mainly audio. And, you know, so when we're at the meeting, we're doing it live. Typically, when Wes and I are just recording the show, we're both talking and recording, and then we release that several weeks later. But for the meetings, we'll bring our guests on, and we'll have a live stream, and it brings some cool
kinda
things to
fun.
the meeting too.
We have a good time with it.
Yeah.
So we learn a lot, too.